All right, you guys. So we are going to finish up with this last section of the thoracoskeletal mini unit that I have for you guys. The next one we're going to jump into is what we call kyphoscoliosis. And this is a mixture of a couple of different diseases. You might have heard of scoliosis. I remember being a kid in elementary and middle school, kind of having screenings for scoliosis. You would be asked to kind of bend over and touch your toes, and a healthcare provider would kind of go down your spine and see if there's any sort of S curvature. But the kyphosis is something that we're going to talk about. It is a combination of this kyphoscoliosis is a combination of that kyphosis and scoliosis, and we're going to see how it's going to impact your respiratory system. It may surprise you how much is impacted by this curvature or this irregularity of the spine. So here we go. So when we look at kyphoscoliosis, like I said, it is a mixture of kyphosis and scoliosis. So you have a posterior curvature plus an S or a C-shaped curvature in the spine. So this is a combination of posterior movement and either an S or a C shape out of the spinal column. So what do you think this would do to and how it would affect the respiratory system? What do you think? Well, one, it's going to compress the lungs on the affected side, and it's going to really restrict any sort of alveolar expansion. So it's going to lead into some alveolar hypoventilation. You're going to have mediastinal shifts. You're going to have an increase in mucus accumulation and even some atelectasis. So we're going to have these patients that have this deformity in their spinal cord that are going to need a lot of respiratory support simply because they will not have the muscular strength to eliminate or remove mucus from their airways. So this will be fun to jump into. So when we look at the epidemiology of this, it's only about 1 to 2% of people in the United States. And when we look at the origin, it's really an unknown origin that leads to this combination. Do you remember what we called it whenever we were talking about something that was from an unknown origin? Yeah, we call that idiopathic. Idiopathic is what we use when it comes to talking about the unknown origin. And you can see that word right here, idiopathic. So when we kind of break this down in scoliosis by itself, this can be a number of different things. It can be congenital, it can be neuromuscular, it can happen from an idiopathic or an unknown origin. It can happen at an infant stage, a juvenile stage, or an adolescent stage. So when we look at scoliosis by itself, there are some specific risk factors when it comes to gender, age, how bad is the angle of the curvature, where's the location, the patient's height, and did they have any congenital spinal defects at birth. So these are all different pieces that we want to kind of be aware of when patients come in and they have scoliosis by itself. This is, again, scoliosis by itself. But when we're looking at this and we're looking at the diagnostics when it comes to scoliosis, we want to get an understanding of that patient's medical history. We want to know if they've had any sort of congenital spinal defects whenever they were an infant, when they were born. So that's a piece that we can getting a good understanding of their medical history. The next thing I want to do is I want to do a physical exam. So this comes with my inspection. Whenever I do and evaluate, does this patient have equal chest rise? I can feel the asymmetrical chest rise. Another thing that I can do is I can put my hand down their spine, just like those screenings that I got whenever I was a kid. you can kind of use a peace sign and go down their back. And if you have any sort of swaying, that is part of that physical exam that could help us see that. The other thing that you can look at is their chest x-ray. You see the spinal process in the chest x-ray. And the last thing that you can look at is, does their torso have some sort of curved movement? And those are all different pieces that we can look at when it comes to identifying or diagnosing this patient with scoliosis. Now, granted, we are not the ones that do the diagnosing. However, we can identify something and we can make recommendations and we can communicate with our providers to let them know that something is off. So I would encourage you, be thorough with your assessments. Be thorough with your assessments and communicate any of your findings up the line so that you can get the patient the right and appropriate interventions that they need, the therapies that they need, so these patients can ultimately do better. And that's what we're looking for, is them to breathe just a little bit easier from the choices that we make. So when we look at kyphoscoliosis, this is something that will impair the cough. We've kind of talked about that. They won't have the muscular strength to move or to mobilize those secretions. So mobilization of secretions create a further struggle with more atelectasis. More atelectasis means more airway collapse and more alveoli that are collapsed. And when they're collapsed on themselves and there's mucus in there or secretions in there, now you have a place where bacteria can harbor and bacteria can grow. What kind of environment does bacteria like to live in? Warm, moist, and dark. What's going on in your lungs? It's a dark cavity. You get humidification from your upper airway, and it's warm. It's to body temperature. So it's a fantastic place for bacteria to harbor. So we want to just make sure that we can do everything that we possibly can to help them eliminate those secretions as much as possible. This is a congenital, or it's a fetal development piece. It is something that happens at birth. There are some neuromuscular components to it as well. Patients or people that have a history of cerebral palsy, muscular dystrophy, spinal bifida, or even polio are all suspect to kyphoscoliosis. So these are pieces that we are aware of. These are pieces that we need to pull from as far as what could be the cause, your etiology. And this is what we're talking about right here. When it comes to the idiopathic or the unknown origin, this takes up the vast majority of the cases when it comes to kyphoscoliosis. 80 to 85% of all cases stem from an unknown origin or an idiopathic cause. So when we look at this, there may not be a etiology that we can pinpoint, but I guess 15 to 20% of the time we can. Now, when we kind of detail this out a little bit more, I was talking about some risk factors, and I used some classifications earlier. When we look at the infantile classification of kyphoscoliosis, this is kiddos that are from newborn or 0 years of age to 4 years of age. We have juveniles that are 4 to 10, and the adolescents are greater than 10. So those are the age ranges that we would break those classifications down at: infantile, juvenile, and adolescent. One of the risk factors that we said was gender, and girls are more prevalent with getting kyphoscoliosis than guys are. When we looked at the age, the younger and the greater the change. So the younger that this happens, the more opportunity you have for more change in that spinal column. So you get more curvature. The more damage it does, the more impact it has on your pulmonary status. The angle of the curve, if you go back and you look at the very first slide with kyphoscoliosis, there's an angle in the spine that's measured, and it's at 90 degrees. So the greater the angle of the initial curvature, the greater the chance of the progression. So the more curvature that you see in that initial curve, the more chance that this will progress to get worse. Depending on where the location is, if it's in the middle to lower, it's less likely to progress than if the curvature happens at the upper portion of the back. Taller people have a greater chance of progression, and those with congenital spinal defects are more likely to have kyphoscoliosis as well. So that spinal bifida and other congenital spinal defects.